Thank you, Dr. Mead. It gives me pleasure now to introduce Anthony Back, MD. Dr. Back is a professor at the University of Washington School of Medicine and co-director of the Cambia Palliative Care Center of Excellence at the University of Washington. He is a co-founder of Vital Talk, which is a 501c3 foundation that teaches clinicians communication skills for serious illness and has an ongoing video blog and has indeed become a trusted communicator, trusted messenger for us as physicians. Dr. Back's research includes patient-physician communication, and he is a pioneer in the use of video and smartphone apps and other technology and innovation in serious illness care. Dr. Back.
Thank you. It is a great pleasure to be part of this workshop. And I think that while communication may seem like old hat, I mean, a number of the speakers already have stressed the importance of it. I mean, the reality of it is that right now there is a lot happening in oncology. And actually, oncologists, the ones that I work with and the ones that I talk to across the country, they actually feel more overwhelmed than ever with the explosion of new drugs, with the new administrative hassles that new drugs create, with the expectations that patients have, and also what I would call internet effects. I mean, yeah, I used to think of this as the Dr. Google effect, but actually now what I really think it is, it's your Facebook newsfeed. Right? If you have ever looked at the Facebook newsfeed of one of your patients, you will be astounded at the bewildering array of stuff that comes at them about cancer. And I think what that means now is that actually the clinician-patient dialogue is more important than ever. Right? A few years ago, Ron Epstein and Rick Street developed this patient-centered communication in cancer care monograph. They named 6 domains of communication that I think are worth calling out because you can see what their strategy is. The first one was exchanging information. We've heard a lot about that already. The second thing is about making decisions. The third thing is fostering healing relationships, which is that trust issue that people were talking about at the very beginning. The fourth thing is enabling patient self-management because actually so much of their life happens outside of clinic. The fifth, specifically for cancer, is about managing uncertainty. And then the sixth thing is responding to emotions. I think this gives you a really important high-level snapshot of the skills that cancer clinicians, oncologists, nurses, the entire interdisciplinary team needs to have. And in the face of these other demands that I was talking about, it makes it harder than ever. I mean, most patients who get cancer now, and I'm talking more about cancer care than the prevention space, they are coming into cancer centers through advertising. And here's the data about advertising. And actually what you can see is the amount of advertising over the past 10 years has increased quite significantly. But if you look at that little yellow line at the bottom that's starting to creep up, and notice this ends at 2014, that is internet advertising. And in the period of this study, the amount of money that cancer centers spent on internet advertising increased 15-fold, right? This is just the tip of the iceberg, honestly. And so then, patients get to clinic, and then at least in the serious illness space, I mean, this is what they're hearing. This is what they've been hearing for 20 years, right? Do you want us to do CPR? Do you want us to pump on your chest like you've seen on TV, right? And, the reaction to that is like, oh my God. It really is a matter of training and the expectations that our community puts out that will determine what these introductory messages to the world of cancer care are. I think Ms. Sampaio was talking about introductory messages for teenagers and suggested that actually maybe we should start with health and well-being. I mean, in a way, I think what we should be starting with for the serious illness space is how do you live well in the face of having cancer? That is how you get started. The really important conversations will come later, but you need to get started here, and that takes training, right? Physicians are not good judges of how well they communicate, right? This is a dot plot of each of those dots represents a internal medicine resident at the University of Washington. We're top 10, residency program, and we ask them to rate their own skills in the palliative care space, and then we asked their patients, right? If they were well calibrated, all these dots would fall along this yellow line. But, what you see is there's no correlation. And this is the observation that many of you have had in your cancer centers, right? It's all over the place. There's like this one person way down at the lower left who is really honest and really bad, actually really close to the red line. And our tendency has been to just throw up our hands about these people and go, okay, there's nothing we can do. We just have to wait till they retire. And here's what these practicing physicians say. This was a large national study where they asked physicians, what do you think about advanced care planning and goals of care? And, 99% of the national sample said it was important or very important, but only 14% said that they actually had a conversation and documented it. And, why didn't they do it? Well, they didn't think they had time. They're not sure the time is right. They weren't sure the patient is ready. They're not sure what to say, 46%. And I think what this is telling me is really it reflects that they haven't had any formal training. I mean, the reason that in the space of health literacy, and all these functions depend on understanding the level of health literacy that your patient has. If you haven't learned how to assess and respond in real time to the level of literacy that you are seeing, you're going to go in and do what we have seen on studies for 20 years. Doctors, well-meaning oncologists go in, they have kind of a routine, they lay it out, the patient goes, for like 5 pages of single-space type text, and then they go, okay, here's what we're going to do. And, that is not really what patients need. And many patients aren't even as obvious as this, right? They are trying to be polite, they're trying to be good patients, they are scared to death, right? And so what happens is, the real conversation, the kind of conversation that our earlier speakers have been talking about, doesn't happen until much too late. How often do oncologists respond to this, in the way that actually improves communication? We were talking about this. This study, which was done by a couple of colleagues of mine at the University of Pittsburgh and Duke, these are comprehensive cancer centers. They're places you would want your family to go for the best current technical treatment. And yet in these clinics, when these oncologists were, and these were only attendings, right, we're seeing patients with advanced cancer, they made an empathic statement in response to an emotion in 1 out of every 10 conversations, right? So that means if you have the bad kind of lung cancer, metastatic lung cancer, you probably have heard one verbal explicit expression of empathy from your oncologist in your entire disease course, right? And it's really not even just about being nice, right? I mean, there's data that shows when doctors and nurses respond to those emotion cues, patients process more and they give more information back. They actually tell you what is really on their mind. So the reaction that, I think Ms. Sampaio was talking about her own cancer experience where, all of a sudden her mind just went blank. I mean, that is a expected, common phenomenon that clinicians need to be trained to know how to deal with, right? And you can train them, it turns out. If you do the right kind of skills training, physicians can use more empathy, they ask more questions about understanding, they explore more values in an active way. These kinds of results have been repeated in a series of empirical studies over the past 2 decades, and they're very robust. What has not been available, though, is access for every practicing clinician in the U.S. Because now, as we followed these study cohorts longer, it's very clear that although I was trained to avoid conversations about how bad things were because it would upset people, right? The real data shows that having these conversations improves patient outcomes. Patients get more of the care that meets their goals. They rate their experience more highly. They don't get unwanted aggressive care. They are in hospice for longer. And in their bereaved family members, if that's where it goes, those bereaved family members have less depression and anxiety. So really, this is not anymore about just being a nice doctor, and it's really not even anymore about just the art of oncology. It's really about a skill set that every oncology clinician should have. And, just to get back to the empirical issue of trust, because I think that's so important in cases where health literacy is not high, actually trust is what enables patients to get the best care. And in this randomized trial of attending oncologists who were trained in empathic responsiveness, trained oncologists use more expressions of empathy afterwards. Their patients rated their trust in their oncologist as higher than the patients of the untrained control physicians, right? So there's really a large preponderance of data out there that shows that communication is a learned skill. It's not something you were born with, and it's not something we should expect our clinicians to be born with. We should expect that our learning systems, our education systems, and our workplace continually train and tune up these kinds of skills. So that, I went from a couple of decades of doing NCI-funded research to starting a 501c3 with a social enterprise focus because we wanted to reach physicians knowing that, if we wrote one more R01, it would take, 5 years to do, it would cost $3 million, and we would have trained 40 oncologists, right? And there are 20,000 practicing oncologists in the US. And so we started Vital Talk with the idea that it makes communication skills learnable. We have an evidence-based learning model, and we have over 500 faculty who've done, over 600 workshops in the past 3 years. These workshops are not just about listening to people talk. It's really about practicing. And you can see here, one of our co-founders, Bob Arnold, watching a nurse practitioner practice with a person who is an actor playing a patient who has incurable melanoma. So after doing this for now a few years and that level of scale, I have learned a few things about strategies that are worth knowing about as we enter into the space, even in new areas beyond just serious illness, into health literacy, into prevention, into survivorship, right? Into diversity issues, that we need better cognitive tools that are teaching tools for clinicians. Instead of this one-way biomedically driven jargon, which many of them have learned because they need to know that to do a technically excellent job, we need protocols for them that invite two-way patient-centered exchange, right? If you train people to ask questions every time, they will do it. And this is the kind of protocol I'm talking about. Expect emotion, notice that. Align with the patient and family, right? Those are trust-building steps, just to call out a couple of things here. These educational strategies need to address both the clinician and the patient side of the equation. Now, we don't train patients directly, but we enlist and get buy-in from clinicians by focusing on their pain points, and we ground our protocols in psychological and learning research. Third is design situations for positive affect. Doctors have been raised with blame and shame, and we need experiences of deliberate practice to create success for them. That's why we work with actors. It's expensive, but you can actually scale it. And here's an example of how we did this at Kaiser Northern California, 21 hospitals, 7,000 doctors. Finally, leverage group and peer learning. Instead of this individual clinician, you're good or you're not, we need to make the team the locus of communication. We need to make these conversations distributed across team members. So policy proposal 1, evidence-based communication ought to be widely disseminated. These ASCO guidelines from a couple of years ago contain many of the solutions that can easily be translated into policy, and I'm going to highlight a couple of them here. I mentioned the one about training, but the second one I want to mention is that health systems and cancer centers should embed communication educators who are clinicians, people who walk the walk, who can do workshops within their organizations and actually respond to all the new things that are coming, respond to new side effects, respond to new programs, respond to new challenges like how cancer patients deal with opioids. Proposal number 3 is payers should create incentives that reward clinicians and systems for participating. So Vital Talk is now doing a pilot with Blue Shield of California to incentivize their physicians And I think these kinds of initiatives represent cross-sector collaborations that improve the quality of care, that leverage all the pieces of the system. Finally, I think public reporting, and this is a recommendation that we developed with the Center to Advance Palliative Care, public reporting of system and clinician measures ought to drive accountability. How many clinicians have been trained? What do patients say about their experience with serious illness conversations? What do patients say about whether they thought that the clinicians were really listening to them, right? Those ought to drive accountability. So I see the yellow light, so I'm going to stop there. But what I want to end with is that I actually think that the issues related to improving the capacity of clinicians to respond more fully to patients, do all the things the panel before me was talking about, even in the setting of lower health literacy, those tools are ready to scale, and policy recommendations ought to be directed at scaling what has been proven effective already. Thank you very much.